Welcome to the NEI podcast. In today's episode, we're coming to you from the 2024 NEI Synapse in Las Vegas, Nevada. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Well, hello there. My name is Dr. Manpreet Singh, and I'll be answering your questions about my joint presentation with the illustrious Dr. Stephen Stahl. Don't get mixed up, recognizing and treating mixed features across the lifespan. So you had a few really amazing questions. I'll try to go through some of those. The first question is, I understand the importance of not missing bipolar depression, but find many individuals who have been diagnosed as bipolar have issues with anger management and or substance abuse and have been misdiagnosed. Has that been your experience? 100% for the person who posed this excellent question. It is absolutely true that co-occurring substance use and anger, dysregulation of emotion, they're cardinal aspects of mania in terms of risk-taking and emotion dysregulation. So the first thing to do in those contexts before you go down the path of thinking that it's a misdiagnosis is ask yourself if this is part of the condition itself. Is this part of the mania? Is this how mania expresses in this individual with anger management problems and substance use? A lot of patients use substances to compensate for when their lows are really low and they want to get up, or when they're really high and want to come down. So the self-medication problem is also an important aspect of this. It's important when you do an evaluation of the diagnosis to really be confident that you haven't missed aspects of the bipolar disorder that could be better managed through optimization before moving on to adjunctive treatments for additional management of emotion dysregulation or substance use treatment. Of course, you can tell oftentimes with intoxication and withdrawal symptoms. Some of them overlap with mania symptoms, right? But they're usually episodic and they are temporally related to the use of a drug or a withdrawal from a drug. So that history ends up becoming very important to rule in and rule out before you move to thinking about it as, again, part of the mania. I just ask patients, so have you been recreating with any drugs recently? Have you found that you've needed to reach for recreational drugs? Have you had a short fuse? And understanding those behaviors in the context of a manic or depressive or mixed episode can be very valuable, because if it is really all part and parcel of the mania, then it's important to make sure that you treat accordingly and optimally. The next question is, please contrast depression with mixed features and mania with mixed features in terms of diagnostic and treatment implications. All right. So this is just basically what is the mixed feature associated with. Is it a depressive episode, like major depressive episode with subthreshold mania symptoms, or is the main episode mania and then associated with mixed features? You could have a mixed episode where patients experience the juxtaposition of depression and mania at the same time. But as we said in the presentation, mixed episodes can sometimes be very difficult to diagnose. It can be very hard to meet all of the criteria for a depressive episode and all of the criteria for a manic episode all at once, in addition to having the individual diagnostic criteria for each of those respective conditions. So when we went to DSM-5, we said, look, let's not think about this kind of in the categorical way. Let's understand that there's a predominant mood like depression or mania, and that they may be intermixed with some mixed features. And then the mixed features are described in DSM. You can kind of get a sense of what are those symptoms that co-occur with or are juxtaposed with a predominant episode. So that's what the contrast is about. It's to understand what's the primary episode that we're indexing with which these mixed features are implicated. The next question is, when you talk about comorbid substance use disorder being associated with DMX, do you consider daily or almost daily use of a modest dose of cannabis? I don't rule out or rule in cannabis use. I don't ever assume that it's not a part of the mix, but I do definitely think about it in my differential diagnosis. And cannabis is a very common drug of choice to bring people into a more favorable, in their minds, mood. The challenge is longer term. It puts you at increased risk for psychosis and increased risk for very difficult to treat depression. So cannabis use, even daily or modestly, is a real problem. And in the long term, what you have to do is engage with the patient about why is that adjunctive use of cannabis being implemented? Is it possible that you haven't optimized the primary bipolar disorder adequately, that it's requiring people to reach for other things? And again, cannabis in the acute term might be very helpful to a patient, bring them down. Oftentimes patients are using it to help them sleep at night, but in the longer term, very complicated and can potentially lead to other problems like psychosis. How can you tell the difference between ADHD and mania in children? Very important question. There are clear indicators that if you have just bread and butter ADHD, the mood symptoms aren't nearly as prevalent. There are some cases of kids with ADHD who also have mood symptoms, but mood problems and hypersexuality and other aspects of bipolar disorder risk-taking are not common in youth with just bread and butter ADHD, who oftentimes don't find themselves to be internally distracted like the kids with bipolar disorder who are distracted by their racing thoughts. They tend to be externally distracted with the construction rigs outside or the people in their classroom twiddling their pencils. Those external inattentive prompts or triggers tend to be more common in kids with ADHD, whereas kids with bipolar disorder are internally distracted. So there are a few telltale signs. Family history is more common in bipolar disorder. Stimulants tend to help kids with ADHD and tends to get better with time. Bipolar disorder is more progressive. These are some of the clues that help you understand the progression as you watch for ADHD evolve and mania evolve in kids. Also appreciating that they can co-occur. So what I like to do in that context is really assess whether I've found an index manic episode, because it's really the defining feature of bipolar disorder, and then go from there. Can you speak on how to identify complex PTSD versus bipolar in adolescents and adults? I think this is a really important point, and I think we want to drive home that individuals with bipolar disorder, adolescents or adults, might be very prone to being victims of abuse, sexual, physical, emotional. In part because of the disorder, they may burn bridges with others because of their emotion dysregulation and difficulty managing their irritability. And so when they get into these unfortunate social interactions and might even have very, very significant deficits in social functioning that could potentially place them as victims of trauma or trauma exposure. Patients with bipolar disorder might have family members with bipolar disorder who are also similarly dysregulated and might be abusive towards them. And so you have these kids that may grow up to have complex PTSD. And what's important here is that the hyperarousal in PTSD that presents and looks like hyperarousal in mania is very characteristically, qualitatively very different. The anxiety is usually very high in those individuals, and the arousal symptoms are more physiological, whereas patients with bipolar disorder have activated states that may or may not correspond with increases in heart rate or blood pressure or fainting or other complex PTSD-like symptoms. So those nuances are context dependent. It also helps to see how these symptoms hang together with other conditions or other symptoms, and also appreciating that the comorbidity ultimately might end up being a very real possibility. So I know it's complicated to have to not just tease apart bipolar disorder from PTSD, but to also imagine that there could be these things co-occurring. But it's a good history at the end of the day that helps you delineate and identify these symptoms. And a mania, if you've never seen it, is very classic and very unmistakable. So if you haven't seen it, please see it so that you can not mistake it for other symptoms. How do I differentiate activation from hypomania or anxiety early in after prescribing? This is such a great point. Sometimes it's dose dependent, that when you're pushing a dose, especially for an antidepressant, you're concerned that you're activating a patient. So you have to really give it enough time and look at the relationship between the dosing and the symptom manifestation to understand it's really the relationship between dosing, administration, patient taking it, and then experiencing potentially a treatment emergent activation that is quintessential to understanding it. Similarly with withdrawal, if a patient abruptly stops a medication, they might show symptom features that look very much like a hypomania or anxiety. So looking at dosing and how a patient took the medication in relationship to their symptom manifestations is critical to differentiating activation from the stable symptoms that you're trying to treat. It's not easy, but it is something that does require some skill and clinical acumen to distinguish. How do you explain the boxed warning with your patients? Yeah, boxed warnings are benign at this point. I think well known to most people that they're there to protect patients. I try to be very plain about what the box warnings say, and if I don't have a great way of talking about it, I'll just read the box warning with the patient to make sure that they understand what the concerns are. I also balance that box warning with data about how important it is not to avoid treatment because of the box warning, and to use it really to context build in terms of what to look out for, so that patients aren't scared away from treatment, and that the data are really unclear about whether or not there's a causal association between antidepressant use and suicidality. Because there are, again, a number of different evidence data points that suggest that if you don't prescribe, you're also at risk for increased suicidal ideation. So the damned if you do, damned if you don't is buffered by providing patients with all the information you can. How do you weigh long-term exposure to an antipsychotic and consequences of that, metabolic movement disorders, when started in childhood? Such a great question. When you start these medications early, you're imagining a very long ramp of being on these treatments for a long time. And in the absence of any evidence that helps us prescribe kind of episodically and naturalistically the way patients potentially present in episode and out of episode, we have to think about these medications as prophylactic or preventative for future episodes, and that untreated bipolar disorder is neurodegenerative. And so I try very much to weigh those risks of untreated bipolar disorder against exposure to AEs in terms of my risk-benefit discussion with patients. And that sometimes does help, especially if a patient is coming in with a parent with bipolar disorder who understands the neurodegenerative aspects of bipolar disorder. The metabolic and movement disorders can be managed as well with medications, adjunctive treatments to help. For example, metformin may be used for buffering and mitigating the metabolic consequences of second-generation antipsychotics. You can use medications to address movement disorders, though in kids, rather than using agents, what I've found most helpful is really careful dosing. If you give the patient's children the right dose of medications, you can actually avoid movement disorders altogether. If you remember when aripiprazole first came out, we were dosing it in kids like we were in adults, and kids were getting doses of 10 milligrams of aripiprazole right off the bat without any dose titration. And those kids became very dystonic immediately after dose initiation. And so that really becomes a start low, go slow phenomenon. Do you favor short over long-term atypical antipsychotic use in kids to spare cumulative lifetime burden risk for tardive dyskinesia? This sort of alludes to my point, is that in the absence of having any evidence to help us understand short versus long-term atypical antipsychotic use, we have to go with general guidelines that longer-term use is important for the prevention of future episodes and supporting kids with psychotherapies and other treatment armamentaria, so that if they do develop long-term consequences of these medications, they can be mitigated or switched. So in those situations, I might consider alternating between a mood stabilizer or an atypical antipsychotic for mood stabilization, just to change things up. We do not have enough data to help us understand the long-term lifetime burden of tardive dyskinesia in these kids, but it is certainly a risk to consider, especially since initiation of medications is going to start very young. And the other thing I should just mention in passing is that we are really excited about the next generation of novel therapeutic strategies that are coming online. And those novel therapeutic strategies, I think, are going to be very helpful to change the landscape of risk for tardive dyskinesia and other dopaminergically modulating medications that may or may not be directly impacted or modulated with the next generation of novel therapeutic strategies. Would you use olanzapine samidorphan in children? I think I would consider olanzapine samidorphan in children. It has not yet been studied, but I do think that kids who are stabilized on olanzapine effectively in an inpatient setting are going to run the risk of developing metabolic syndrome if not given co-occurring metformin or some other medication. And in this context, olanzapine samidorphan could potentially be valuable. It is important to think about the context of samidorphan and its effect on maybe less a metabolic impacting agent and more of a weight interacting drug, but the data still remains to be seen in kids. And so we really need an olanzapine samidorphan trial in pediatric populations to help us understand its potential utility. It almost makes me think that for bipolar 1 depression, we ought to have considered this medication or other strategies rather than combining olanzapine with fluoxetine, for example. But we are where we are with that data, and it is clearly an impactful and effective drug with very good efficacy, even in kids. So I'm not sure that we've said goodbye to olanzapine at all, for that matter, in youth, even though we do know that it has a very high metabolic liability. Is there any evidence of the efficacy of dextromethorphan, bupropion, Auvelity on DMX? That's such a great question. And I think that there may be some potential emerging data to suggest that dextromethorphan combined with bupropion could potentially be useful for depression with mixed features, but I'm not aware of data off the top of my head to be able to comment on that. Hopefully we can do a literature review and look to see, but my impression is that this is really a medication for treatment refractory or difficult to treat depression, unipolar depression. If significant symptoms are present only in pre or perimenstrually, should we have greater concern for bipolarity? This is an interesting point. There was a really cool article in The Atlantic that talked about how menopause is such an important condition that women who experience menopause are getting short-shrifted, because conceptual framework for how we treated menopause symptoms was to do estrogen replacement. But after we learned that menopause is also modulated by changes in estrogen and testosterone, did we become a bit more nuanced? And I think that the point being there that hormonal changes in youth and adults can have a significant impact on moods, and we ought to understand the onsets and offsets of moods and see if hormone replacement could be of value to patients, because sometimes that just does the trick, and then you can circumvent needing to go down the path of treating patients with psychopharmacology. But in terms of differential diagnosis, what I think the menopause example shows or illustrates very nicely is that, we aren't just on one categorical, monolithic conceptual framework anymore for symptoms that present perimenstrually or perimenopausally. They are complex and dynamic and dimensional, and so must be conceptualized that way when we treat patients. Should we be thinking about bipolar disorder? Of course, if there's any hypomania or mania symptoms, then bipolarity ought to be part of the differential. But more importantly, the hormonal context of those symptoms can really afford a clinician an opportunity to treat the underlying cause of the mood symptoms and holistically, so that patients get the right first treatment and are augmented accordingly if that treatment doesn't work, or sequentially switch to something else that maybe work better. And I have a lot of patients who may have been undiagnosed or misdiagnosed because of the hormonal changes. And this is why mood charting can be super, super helpful to help capture the patterns of symptoms in accordance with cycles. So I hope that's helpful. And it's all the time we have today. I really thank you for your questions and hope my answers prove useful to your practice, and can't wait to see you all again.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.